Hello, and welcome to the UsTOO support group meeting and webcast on chemotherapy. My name is Chuck Strand. I'm CEO of UsTOO International. We are a prostate cancer nonprofit that's focused on providing educational resources and support services to the prostate cancer community at no charge. So we'd like to not only thank all of you for coming here today, and we've also got some folks who are watching the webcast online. So this is a great opportunity to be able to reach a lot of people that may not be familiar with the support group meeting. And so we're happy that all of you are able to join us in person and on the internet. We'd also like to thank our sponsor, Sanofi Genzyme, for providing the funding for this event. So one of the core services that we offer as a nonprofit are the network of support groups. So we've got more than 200 support groups throughout the country, and some are abroad, and the majority of these groups are led by volunteers. Some really amazing men and women who are really dedicated to making sure that there's a quality experience every month at these support group meetings. So they work really hard to organize the speakers and call the folks to remind them to come, provide the opportunity for the exchange of information. So we've got a list of all the support groups from the UsTOO network that are available on the UsTOO website, which is UsTOO.org. So please check out the website if you're interested in seeing where those groups are. Hopefully there's one near you. If there's not, we're always interested in getting more people to step up and volunteer to lead a group, so please let us know. In addition to the in-person support groups, we also have the online support group through Inspire Community. So there are more than 14 different topics that are organized under the prostate cancer community. And if you're interested, you can, again, no charge for that. You can log on and post a question or respond to somebody else's question in any of the 14 categories. And there's also the ANCAN, which is a conference call. So we've got conference call support groups a couple times a month, and that's in collaboration with ANCAN, Answer Cancer. Lots of different opportunities for connecting with people and recognizing that there's real value in learning from other people and exchanging information, in addition to having the speakers that are often part of the support group meetings. And again, the support group that's being webcast tonight is going to be videotaped, so it's also going to be available archived on the UsTOO website. And this provides a great opportunity for people to have a window into what it's like to be at a support group meeting. Some people may not have the opportunity due to geographical limitations or physical limitations, and some people might not understand what happens at a support group. Granted, every group is different. They're all volunteer-led, and they're all managed independently, but there are also some very common elements of a lot of value that goes back and forth between this exchange of information. So we'd like to invite everyone to feel free to submit questions on the website or the webcast. You can just do that in the open field, in the chat screen. You can send in your questions, and we'll do our best to get to all the questions during the Q&A throughout the presentation, and hopefully we can get to everyone's question. And at the end of the event, we'll be sending out a survey. Actually, that'll be tomorrow. So if you can please check your email box, and if you can please provide the feedback from the webcast tonight, that's much appreciated. We want to make sure that we're doing the best we can as far as servicing the prostate cancer community. And the content here will also be valuable for the support group leaders to use in future meetings. So as I mentioned, we've got a lot of great people that have volunteered to do this. The support groups throughout the country. So we'd like to thank all of the support group leaders around the country for all they do every month. We'd also like to thank the venue here tonight, Holy Family Church, for hosting this event. And we'd also want to throw a shout out to Tim Mix, who's our communications manager at UsTOO on staff, in addition to Terry Lukowski, who is really the point person for all the support group leaders and all the support groups throughout the country. So she does a great job in coordinating all of the different interactions and providing information and leading calls once or twice a month to exchange the information that's valuable in terms of best practices and sharing common challenges that the support group leaders face. So again, to thank our local support group leader, Cliff Whall does an awesome job. He's been doing this for years, And we truly appreciate all that Cliff does every month. And I just wanted to say thank you to Cliff and introduce you to Cliff Whall. Thanks so much, Cliff.
Thank you, Chuck. Appreciate that. Let me... I was asked to describe a little bit how I got here, why I'm the leader of the group, and why I'm even in UsTOO to begin with. I was diagnosed, well, first of all, I'm what's called a prostate cancer warrior, survivor and a warrior, because everybody that's in this it's in a battle, and you're warriors and you're fighting this disease, and it's getting better and better all the time. There's more and more treatments coming out. So it's really a good time to be. I've heard it said that if you're going to get prostate cancer, this is a good time to get it. I was diagnosed in 1998, and like probably everybody who's ever received a prostate cancer diagnosis, you panicked. You didn't know what to do. What do I do now? There's that dreaded word, cancer. So I started looking around trying to find information, and I found UsTOO. And UsTOO, I was in a support group like this where I went to their meetings, and the people there, and along with UsTOO, provided me the information I needed to be able to make an informed decision about what treatment I wanted for me particularly. And that's what our group does now. We help people, we teach them what's available, where the resources are, what kind of treatments there are, and then they can make informed decisions. I ended up having a radical prostatectomy in 1998. I investigated several options, and we encourage everybody to do that. Look around, get different opinions. I went to several urologists. They're the ones that cut out the prostate. I went to several people that do brachytherapy, which are radioactive seeds that you insert in the prostate. And then to get an unbiased opinion, and I wonder if he remembers, I went to Dr. Shevrin, who's our speaker tonight. Now, Dr. Shevrin is an oncologist, and he said, "What are you doing here?" Because I had fairly early prostate cancer. And I'll never forget what he said. He said, "You could do either one. Get out of here." He didn't quite say it like that. But it was reassuring that what I wanted was an unbiased opinion. You know, urologists might say one thing, brachytherapists might say something else. He was an unbiased opinion. He said either one would work in your situation. So that was comforting, and I chose what I did. I've been very fortunate. I haven't had a recurrence. It's been almost 20 years now. It turned out that it was fairly early in the process, and so, you know, possibly I've been cured. I always say possibly because you never know. Soon after that, I decided, boy, I'd received so much help from UsTOO and the chapter and the people in there that I wanted to give back. So I got involved in the support group in 2000. And it was called the UsTOO Bill Blair Russ Gould Support Group. Bill Blair and Russ Gould were two people that were very instrumental in forming this group, very knowledgeable, and kept it going for years. Unfortunately, they both passed, so the mantle has passed on. And that Russ actually passed away in 2013, so that's when I became the leader of the group. The why up there is, I already said why. I'm doing it to help others the way I was helped. And every time somebody comes here and says, "Thank you for the information you gave me, you helped me a lot. I made a decision I'm happy with," it makes me feel good. It makes all of us. And I'd like to acknowledge two other people that are on our steering committee. Harvey Orlov is over there, and Charlie Peterson. They're doing the same thing I'm doing. And we encourage anybody in any of the groups that are out there. The steering committees always need people to help to keep this thing going. So if any of you feel at all like you'd like to give back, let your leader know and come forward. It doesn't take a lot of time, and the more people that are doing it, the better we can do it. So I'd like to welcome everybody. Chuck already welcomed you, and I'd like to welcome you as the local leader. We have our monthly meetings here at Holy Family Church, the fourth Tuesday of every month. Immediately next door, there is another group of individuals that get together and talk about, those are individuals that have very advanced prostate cancer, so they'll have metastases, And they get together, and their format is different. They go around the room and they talk about what their situation is and try to help each other. Our group is much more general. We have people from that group that attend here, but we go over many different topics. And I did want to say just a few things about our group. So we have members that have been here for many years and keep coming back, and we have new members. Every time we have a new member, we ask them to tell us their story. Where are they at in their search for whatever treatment they would like? And then we offer to help them. So we always want new members to show up. When we do that, we put them on our mailing list so that they can now get news of future meetings. We cover a variety of topics. So one tonight is chemotherapy. So we cover topics looking at early treatments for early and advanced prostate cancer. Tonight we're going to be talking about treatments for advanced prostate cancer, one of the treatments. Treatment effects on issues such as sexual performance, urinary incontinence that result from treatment. What can you do about those things? We have our members sometimes come up here in a small panel and tell their story. And then there's an interaction between the panel members and the people in the audience. And those are very popular meetings. Everybody wants to know what everybody else is doing and how it's worked and where they did it. So those are always nice meetings. So we have a lot of experience in this group. Together with the experience that we have, and I'm sure this is true with a lot of the groups that are out there, we can do a lot of informing. That, together with everything that UsTOO offers, all the information that UsTOO offers, can help men make an informed decision about what treatment they want. And that's the key. Make an informed decision. Don't jump into anything. Get several opinions, go to different doctors, and then you can come up with a decision, and then you discuss that with the doctor of your choice. And I'll just give one disclaimer. We are not physicians, so we're not telling you what to do or how to do it. We're just giving you the information. We encourage you to always talk to your doctor about what treatment option you're going to do. So I have one other thought. I thought this would be an interesting slide to show you. Bill Blair and Bill Blair used to always end his talks with this slide, because he was a prostate cancer warrior, and he never gave up, and neither did Russ. And they fought, and they helped a lot of people, and we are the legacy. We're trying to keep it going. So now I'd like to introduce Dr. Shevrin. He's our speaker today. He's a medical oncologist at NorthShore University HealthSystem, an associate professor at the University of Chicago. He has more than 30 years experience with prostate cancer, and is affiliated with Glenbrook and Evanston Hospitals and director of the Kellogg Cancer Center at Glenbrook. Dr. Shevrin, we're excited to have you here tonight.
Thanks. Is this working? We're good? All right. Put this down here. Well, thank you very much, Cliff, for that introduction, and I want to thank Chuck, Strand, Terry for organizing this. It was about a month or so ago, or maybe a little longer, that Terry and Chuck asked me to give this talk to the group here, but also to have it streamed. And so, I want to say hello to everyone out there who is streaming this, sitting in their nice warm house somewhere in front of their little computer. They probably have the TV on next to it, so they're watching. If it's getting boring with here, they'll look at the. I think, is the game on now? I don't even know. Doesn't matter. Who cares? It's not. We don't care, right? But I do. Oh, sorry about that. Thank all of you for having me. And I think what we're going to talk about tonight in terms of chemotherapy is a very, very important topic. Even though probably most, if not all of you, have never had chemotherapy. Have any of you had chemo? No. And that's fine. I hope you never have to. Really. Right. And I suspect, I don't know how many out who are streaming this have had chemotherapy. Again, probably the majority have not. and that's okay too. But it's an important topic, I believe, to discuss so that men with prostate cancer understand the role that chemotherapy plays. Just as an introduction, as Cliff said, I've been doing this for over 30 years. And over those 30 years, things have changed a lot, although sometimes things haven't changed a lot. For instance, giving hormonal therapy, that's been going on for well over 60 years. Okay, so that hasn't changed. I mean, aspects of it certainly have changed. But the basic concept of giving hormone therapy as a basis for treatment of advanced prostate cancer is something that's been around for many, many years, since Dr. Huggins won the Nobel Prize in 1941 and discovered it. Chemotherapy is a little bit newer. Now, chemotherapy has been around for years and years and years in the treatment of various cancers, originally treating childhood leukemia. Nitrogen mustard was the first chemotherapy drug that was discovered when in World War I, men coming back had low blood counts, and some very smart scientists at the Brigham at Harvard began to connect the dots a little bit and started coming up with developing these drugs, which are truly poisons. I mean, nitrogen mustard. But they found out by adjusting the doses and giving these in combinations, ultimately, they were taking kids with leukemia who would routinely die and beginning to cure them. And then this moved on to other cancers like other adult leukemias, lymphomas, and then broke into solid tumors, and then, as we'll be talking about, even to good old prostate cancer, okay? So let me move on here. So what is chemotherapy and how does it work? Okay, so just some general points. So unlike hormone therapy, and I think all of you know how hormone therapy works, when testosterone levels fall, cancer cells prostate cancer cells that require testosterone to grow and survive without it will undergo what's called apoptosis, which is the scientific term for programmed cell death, meaning they just go into a death spiral, and many of them die because they do not have testosterone. And that's great, because, you can get a great deal of benefit from doing something like hormone therapy. There's no such thing as hormone therapy for lung cancer or colon cancer. That doesn't work. There is for breast cancer. There are some similarities between breast and prostate cancer. But for lung cancer and colon cancer, when you have advanced disease, there's no choice but to give chemotherapy. Okay? That is the treatment. Now, there's others as well. So chemotherapy, in general, directly attacks a cancer cell, directly. Okay? Now, yes, they are kind of a poison, if you will, but these generally affect rapidly dividing cells. Okay? Rapidly dividing cells. Let me see if this will work. Rapidly dividing cells. Okay? They will frequently directly damage DNA. DNA, which is, all of what life is made of. The DNA is the code, and if you screw up the DNA, you're going to screw up the cell, particularly when it goes to divide. Okay? You all remember from high school, college biology, mitosis is when a cell divides from 1 to 2, the 2 daughter cells. Some chemotherapy drugs affect metabolic pathways, and some, particularly the ones that are most relevant to prostate cancer, damage what are called microtubules. Well, what are microtubules? If you kind of remember in your mind's eye, when 2 cells divide, remember, they have the nucleus and then they start to bud apart, you see the chromosomes all line up. Remember, they have to divide, double up, and then you need, 46 chromosomes in each one. And those chromosomes line up on these microtubules. They're like little threads. And the chromosomes literally follow along those threads to each cell. So if you screw up those microtubules, I don't know where, there it is. Is it going on here? If you screw up the microtubules, then you can't get the chromosomes to really move properly, and it really messes up the whole process of cell division. Okay? So these 2 drugs, Taxotere, Cliff, I don't know if you want to, no. Oh, there it is. Okay, I'm moving it too fast. I'm sorry. Two drugs that were used pretty frequently in prostate cancer, both Taxotere and Jeutana, happen to be microtubular poisons. They damage the microtubules, not DNA so much. So that's how they work, a little differently. Okay. Chemotherapy is generally given intravenously through the vein, although some are oral, but the vast majority are given intravenously. Okay. Chemotherapy may be given in combination with other chemotherapy drugs, sometimes as many as 4 or 5 altogether. It can be combined with radiation, not so much in prostate cancer, but the most common is rectal cancer, where radiation and chemo is given at the same time. Okay? And it can also be given with hormone therapy, as we'll see in a little bit. It can be combined. Now, we all know that chemotherapy has a bad reputation, right? If you say chemotherapy to most people, they'll make a kind of a sound of ugh, okay? Well, and deservedly so, because there are a lot of side effects, okay? We all know the side effects. We've heard about vomiting, infection, neuropathy, okay? These are some of the main ones, okay? Infection, people can die of infections. Who wants to vomit and throw up? Can get sores in the mouth, hair loss, etc. What I'm going to talk about, though, is yes, those are side effects, but we've been able to greatly minimize and deal with these unpleasant side effects. But to me, even more importantly, is they can be highly effective, very effective, okay? I sort of look at chemotherapy in some men when other treatments are not working, specifically hormone therapy is not working, or Xtandi or Zytiga or some of our newer hormone therapy drugs are not working, and the cancer is getting worse. We have to put a halt to that cancer growth, or we know where things are headed. And chemotherapy can do that. It's kind of our hammer, to really put the hammer to it, okay? And frequently, there's an improvement in cancer symptoms, bone pain, weight loss, shortness of breath, weakness and fatigue. You think, wait a minute, but doesn't chemo do all that? Yeah, it can, but when you reduce the cancer in your body, it's like a weight is removed, and men feel better. And most importantly, you live longer, right? Isn't that what it's all about? So what are some of these side effects that everyone thinks about, knows about, okay? And have they changed? So, as I said before, these are rapidly growing cells, and cancer, for the most part, are rapidly growing cells. They're out of control, right? They're not following the rules. They're following a different set of rules, okay? Well, there's a lot of rapidly growing cells in our body. One is the bone marrow, right? Bone marrow is the factory for our blood cells. Red cells, white cells, and platelets. They're produced in the assembly line factory in our bone marrow, right? That's the liquid material inside our bones, mostly in our big pelvic bone and lumbar vertebra, okay? And it makes white cells, red cells, and platelets. Well, those cells are rapidly dividing, so when you give chemotherapy, those cells are affected, okay? And they slow down. And so you frequently get a low white blood cell count. White blood cells fight infection. Now, these white blood cells that fight infection fight bacteria, okay? The white blood cells that fight viruses are not affected. So men and whoever gets chemo are typically not affected so much by viruses. You can fight those off, but it's bacteria. Now, where's bacteria? Well, bacteria is all over our body, right? It's in our mouth, in our gut, okay? Red blood cells can drop, and you get anemic, and you can get weak. And platelets can drop. They are cells that keep us from bleeding. So that can occur. Hair follicle, well, mine once was a rapidly growing cell many years ago. I have pictures that prove it, all right? Hair loss, and that's probably, one of the most, thing that most people think about, because if you're getting chemotherapy, you may feel okay and look okay, but If you don't have any hair, people say, oh, the guy must be getting chemotherapy, okay? And especially for women in particular, this is tough to lose hair, okay? The mouth, you cut your mouth, it heals in a matter of a day or two because those are rapidly growing cells. Well, so you can get mouth ulcers. And the lining of the gut, that's where you get the nausea, vomiting, and diarrhea. Also, there can be damage to peripheral nerves, the little nerve tips that go to the fingers and toes, and that's called neuropathy, okay? The feet, bottom of the feet can feel numb, tingly, kind of cold. People who have diabetes can tell you what that feels like, okay? And there can just be generalized fatigue. You just feel tired. You just feel kind of tired. And there are rarely, certain chemo drugs can actually cause heart damage or kidney or lung or liver. These are serious drugs. But most importantly, most of these side effects are temporary. Most of these side effects are relatively mild and are generally reversible. When the blood count drops, it's going to come back up. Hair goes back. Now, when it grows back, everybody teases you because it's kind of a little fuzzy baby hair, but it grows back. Mouth ulcers heal. Nausea, vomiting, diarrhea goes away. It's not permanent, okay? Neuropathy can linger a little bit because the nerve damage heals slowly. They do heal, but nerves heal slowly. Fatigue gets better. And these are rare items where you damage these organs, and a lot of these are reversible as well. Now, management of these side effects has improved. I've been doing oncology, as Cliff said, for over 30 years. I remember giving chemotherapy at Westside VA Hospital. I don't know if you've ever been there. It's now Jesse Brown. And we gave some pretty harsh chemo, and we didn't really know how to manage the side effects, and those men got pretty sick. But things have changed. It's not like that. So, for instance, if the white blood cells, we know that chemo is going to result in a low white blood cell count and infection, we can use medications which are called growth factors, which boost the white blood cells. Tell the bone marrow to make more. If the red blood cells are low, anemia, well, you may need a transfusion or two. And there are also growth factors for that. We have a whole, in terms of nausea and vomiting, we have all of these new medications, which are so much more effective. So the days of going home and vomiting all are over. I can't say never, rarely happens because we have these really, really good anti-nausea medications. Neuropathy remains a little problematic. It's still, we don't have anything that can prevent it totally. But there are definitely better drugs to treat it if it occurs, okay? Hair loss. Well, all I can say is get your favorite team's hat and put it on, okay? No one will know, right? If it's winter, you put a stocking hat, right? We're also much better at properly dosing it. Instead of giving the same dose every time, to do the correct dose or modifying it. Schedule modifications. And this is where the experience and knowledge of an oncologist who treats people with chemotherapy is really important. To know, okay, just because everyone's giving a certain drug is how do you give it? The right dose, the right schedule, okay? There's a lot better patient education. We really go out of our way to teach patients who are going to get chemo so they really know about it. Proper nutrition, extremely important. And here's a really important part of it, and kind of fits into some of the other kind of topics, and that is because of a lot of patients and doctors' fear of giving chemo and concern about making people sick, often it's sort of pushed down the road. It's delayed till later, and sometimes it's delayed too long because there's kind of a window. Because if you wait too long and the cancer is really getting a hold of you, it may not be long before you're just too weak. You're too weak to get chemo. You just don't feel well enough to get it. You kind of miss the boat. The window's closed. So there's a window. You don't want to give it too early, and you don't want to give it too late. And this is, again, where it takes experience of an oncologist to know that. But we're tending to give it earlier when men are healthier and can deal with these side effects much better. Now, so let's talk a little bit about the specific drugs that I give in treating patients in my practice with prostate cancer, okay? As I said before, the two main drugs are Taxotere, otherwise known as Docetaxel. That's a scientific name. Taxotere is a trade name, okay? It is now generic. It was originally, it's a synthesized microtubular inhibitor, okay? It's now generic, so it's actually relatively inexpensive. And when you compare it to some of the exorbitant prices that you're seeing with other cancer drugs, that we're talking $10,000, $15,000 a month, for some of these drugs, Taxotere is, each dose, which is every 3 weeks, might be a couple $100. So in 2005, 12 years ago, two very large, important randomized trials were published in the New England Journal of Medicine, back to back, our most important journal. And these randomized trials compared Taxotere, okay, to, in one case, a placebo and another to prednisone in men who had advanced cancer that was progressing on hormones. Okay, the hormones weren't working anymore. Hormones had stopped working. Cancer was worsening. It had spread. And there was a significant improvement. And it was really on that basis, those two articles, that the FDA said, yes, we're approving this drug for first-line treatment as a standard of care, okay, for prostate cancer. Prior to 2005, there were probably 4 or 5 or even more chemotherapy drugs that we had available to us, and they simply were not effective or minimally effective. They didn't prolong survival. They may help symptoms a little bit. So we were really struggling up until 2005 with pretty ineffective drugs. So prior to that time, it was perfectly reasonable to say, I don't know if I want chemotherapy, if it's going to make me sick and it doesn't really help me that much. But since 2005, we have this very, very important drug. And it remains the standard of care to this day is first-line treatment based on guidelines, okay? The side effects are present, but are manageable. There's rarely infection. The blood count doesn't fall that low in most men, and when it does, there's rarely an infection, okay? Occasionally, and if so, we put them on an oral antibiotic from home and they do fine. It's rare that a man has to come into the hospital with an infection like a pneumonia or a bladder infection so severe that they need intravenous antibiotics. The fatigue is mild to moderate, and it tends to be cumulative. In other words, after you go through 4 or 5 or 6 rounds of it, you get to be more fatigued. Neuropathy can occur, okay, and that is, again, cumulative, often of the feet and toes, okay. There's rarely, if any, nausea. We usually don't even have to send men home on a nausea medicine, okay. There is some hair loss. It's usually not universal, but there is hair loss. There can be some strange, the eyes can tear a little bit due to some inflammation of the tear duct. We give some steroid drops. The nails can get a little darkened, but they grow out. And there can sometimes be a bit of fluid accumulation. So sometimes when I look at that and I describe all of these side effects to a gentleman that I'm recommending chemo, I said, see, hey, walk in the park, right? And they kind of look at me like, that's a long list of not very pleasant things, okay? And if you look at it just, on the face of it, who wants that? Infection. But the point is, you rarely get infection. The fatigue is not overwhelming. The neuropathy is typically not severe. There's no nausea. Yes, the hair loss, but it comes back. The eye tearing and nail changes tend to be mild. The edema is not typically very severe at all. So most men who I give this drug to, I would say 80% of the time when I ask them, how's it going? They'll say, a lot better than I thought. That's usually what they say. I have rarely heard a man say, this is much worse than I thought it would be. Okay, most of it, this is a lot easier, okay? Here's the good part. While you're putting up with some of these side effects, for the first time for some men who have seen their PSAs go up and up no matter what we do, we try Xtandi, we try Zytiga, we try Xofigo, we try Provenge, PSA just keeps going up and up and up, and it makes you crazy. Well, the PSA starts to drop. PSA starts to drop, and sometimes pretty quickly. And it sometimes drops pretty significantly, like 80%. Okay? There's often an improvement in symptoms. Men who are not feeling so hot feel better. Maybe not immediately, but they begin to feel better. Okay? The other drug that's been approved is called Jeutana, or Cabazitaxel. As you can see, the Taxel is sort of the same, so it's also in the same family, meaning it's a microtubule inhibitor. It was actually rationally designed against prostate cancer cell lines grown in plastic that were resistant to Taxotere. So what are we going to do? Taxotere stopped working. What else? Well, this drug was designed in order to overcome that and be treatment for men who have not responding anymore to Taxotere. And in 2010, I could have the date wrong, but it's about that time, a very large randomized trial was done, which showed that it showed significant benefit in men who had already received Taxotere chemotherapy and therefore was approved as second line after someone had received Taxotere. And that's what we generally do, is give this after a gentleman has had Taxotere. Now, very recently, there were several studies published in JAMA Oncology, a very, very critical, important journal, that compared Taxotere directly to Jeutana. And it turned out that they were pretty equal. They were pretty equal. One wasn't better than the other. Pretty equal. Where they're different is in some of the side effects. So the Jeutana tends to cause a little bit more of a drop in the blood count. A little bit more. Again, we don't see a lot of infections, but if your blood count is already a little low to begin with, we may not want to use that one. It can occasionally cause some mild diarrhea. Well, if you don't like diarrhea, then you don't want this drug. Who likes it? But if you have a problem with that or some other issues, but that can be a little. Fatigue is about the same, but you don't see much neuropathy. Okay? So men who already have some neuropathy, either after Taxotere, or who have neuropathy, let's say from diabetes or something else, this Jeutana might be a better choice. So now we're, able to be a little more, a little more judgment rather than, okay, Taxotere's number one and Jeutana's number two, to choose which is actually kind of custom make it a little bit more to each individual. So those are our two main chemotherapy drugs. The last are called platinum-based regimens. There are two platinum chemotherapy drugs that are used for many, many, many different kinds of cancers. Lung cancer, colon cancer, pancreatic cancer have these platinum-based regimens. Well, it turns out that some cancers, and I'll talk about this a little later, certain prostate cancers suddenly become very aggressive, kind of going along slowly, manageable, and then it's like someone flipped a switch. And they really start to grow. And it's pretty scary. Well, it turns out they've developed what's called neuroendocrine features, which means it's aggressive. Okay? And that's where we use these platinum-based regimens as third line, and they can be very, very effective. Okay. So when do we use it? So again, often these chemotherapy drugs are not used until men are very sick or really very far along in the course of their disease. And that has been challenged. So the traditional use of chemotherapy in prostate cancer based on NCCN guidelines, these are guidelines that we generally try to follow. They don't have to, but they're strong guidelines, is that Taxotere should be used for symptomatic men, symptomatic, I put in quotation marks, with metastatic castrate-resistant prostate cancer, right? And you all know what mCRPC is, right? mCRPC, castrate-resistant prostate cancer, means your cancer is getting worse in spite of being on Lupron, in spite of on hormone therapy. Your testosterone level is low. Okay? The treatment's been working for months to years, but now it's not anymore. The PSA is going up. What's going on? Well, these cells have developed the ability to grow with just a tiny amount of testosterone. That we call it castrate-resistant prostate cancer. And we now have a number of drugs, such as Xtandi, Zytiga, and others to use. But Taxotere is currently, the guidelines is that it is to be used for symptomatic men with mCRPC, okay? And that Jeutana is to be used as second line, and platinum to be reserved for those who have the aggressive type. Well, how do you define symptomatic? There's symptomatic and there's symptomatic. You can say symptomatic could be on one end of the spectrum, someone who is so sick they can't get out of bed, can barely come to the clinic, they're having terrible pain that needs morphine, they've lost 20 pounds. Okay, that's symptomatic. Well, we don't want to wait that long. So we tend to look, or I certainly do, when these symptoms are very early, okay? Maybe the pain isn't bad, but a little bit of bone pain. Now, bone pain is difficult to know sometimes. Well, your back hurts. Well, what's that? Is it the cancer that might be in one vertebra, or is it the arthritis that you've had for 15 years? Okay, I don't know. You may have pain in your shoulder or your hip. Sometimes it's not so easy to know. But you have to have some degree of concern or suspicion that it might be from the cancer. Or if you're just not quite as vigorous, a little more fatigued. And certainly if your appetite begins to drop a little bit. Okay, that's a sign. So these are symptoms that oncologists kind of keep their ears open for. Okay, but a good oncologist isn't going to wait until it's just, screaming at you that this man is symptomatic. Okay, you want to do it more earlier. Okay? And so, as I said before, when it's given late, and there's many reasons why it's given late, we'll talk about it. Sometimes it's the urologist's fault because they won't send them to an oncologist. Sometimes it's the doctor's fault. The oncologist says, I really don't want to give you chemo. I don't want to make you sick. You're a nice guy, and, we'll try something else. And sometimes it's a patient. I'll say, you need chemo, and they go, no way. I'm not doing it. I've seen too many people get sick. My neighbor, my friend, my friend's friend. And they have no clue what chemo they got, what disease they had, probably something totally different. But in their minds, it's awful, and they don't want to do it. And it's sometimes hard to change someone's mind, once they get that into their head. So, a couple of things about these studies that are important to know. CHAARTED, what is CHAARTED? CHAARTED is a very, very important study that I was part of that was published a couple of years ago, Chemohormonal Anti-Androgen Treatment in Extensive Disease. Basically what it was, this was a clinical trial that I was actually part of early on to develop it, and that was, Taxotere works well in men with advanced disease when the cancer has progressed on hormone. And it's pretty effective there. Well, what if we use it earlier? Real early, okay? In other words, when a man first has prostate cancer that has spread to a bone or a lymph node, okay, the treatment's going to be hormone therapy. That's standard. You're going to get hormone therapy. Well, we know that probably at that very moment, there's going to be some cells that are the bad guys. They're there. Not very many of them, but they're there. Because they're the ones that won't die with the hormones. Maybe they'll go to sleep, maybe they won't do anything for a few years, but eventually they will be the cancer that grows. And then you have trouble. It's these guys who are resistant from the get-go that we're saying, why not get them now before they grow up to be big cancers? Okay? And that was basically the hypothesis that we wanted to do. So rather than wait, men who were diagnosed with prostate cancer, which it had already spread. We're not talking about prostate cancer in that you're going to just have surgery or radiation early stage. I'm talking about it's already spread somewhere. That all men got hormone therapy, because that's the standard. Everybody got hormonal therapy. But half also got chemotherapy for 6 rounds. Took about 4 or 5 months, and then you were done. 6 rounds of chemotherapy. This is the first time that we even thought about giving chemotherapy earlier and not waiting, okay? And we basically all divided men into if they had kind of an extensive disease, a lot of disease, meaning more than 4 metastasis, or if it spread to your liver or lung, versus much less disease. So what this showed was an incredibly positive trial, at least in oncology, for us, where any improvement in survival is quite welcome to us. And so overall, an average of 11 months, almost a year improvement in survival overall. And these were men who typically live at most 5 or 6 years. It added an additional average of a year of life. And in the group that had extensive disease, where it was a little more advanced, it was approaching a year and a half average improvement in survival. Now, some of you may say, 11 months, 17 months. Well, at least in the oncology world, we considered this a big deal. It was statistically significant. It was heralded by the oncology community. It was presented as the top paper at the ASCO meeting at the McCormick Place and published in the New England Journal of Medicine. And I am the 15th out of the 20th authors. So, hooray for me, right? Okay. So now, the NCCN guidelines recommend Taxotere for men who have extensive metastatic disease, who are just starting off on their journey, getting hormone therapy, to get chemotherapy with Taxotere if they are physically able, meaning they're physically in good enough shape and willing to do it. Okay? So that's CHAARTED, and that has really changed things a lot. So along comes Stampede. This was a somewhat similar trial out of Europe, a big European trial from the EU countries. Multiple arms, very, very big trial. And part of this kind of extensive effort was also similar thing, same thing, men with the same metastatic disease going to get hormone therapy also received Taxotere. They basically did the same thing. They didn't really care about extensive or limited. They just gave it to everybody and didn't divide it up. And basically they showed a difference of 15 months, just about the same. And it confirmed the CHAARTED results. So both in North America and in Europe, these two trials said, you know what? If you have prostate cancer and you're able to get 6 cycles of chemotherapy early on, why don't you do it? Okay? Now, I will add one thing to this, and I've been giving chemotherapy to many men since that data became available to us. But just as a more updated information for you, in the last ASCO meeting in June of this year, a trial called Latitude, which came also out of Europe, mainly out of France and some of the other countries there, took the same group of men, and instead of giving them chemotherapy, they gave them Zytiga, or abiraterone. That is a pill that we use for advanced disease. And you know what? It worked as well. It worked just as well. It did just as well. Just as well. Okay? So, you know, now we have some other things to choose from. You know, do we have to give chemo? Can we give this pill? That pill has its own side effects. It's not really the topic tonight. It's not without side effects. And instead of just getting, in this case, chemo for 4.5 months, you had to stay on that pill until the hormone therapy stopped working. And that could be years that you're taking this pill. And that pill currently, the retail price is $10,000 a month. Okay? Now, no one pays $10,000 a month, but with Medicare Part D, every January 1st, you got to get through the donut hole. That'll cost you $3,000, and then you pay $500 a month the rest of the year. Okay? So it's about $7,000, $8,000 a year out of pocket for that medication. Just saying. Now we have, you know, financial counselors who can help if you can't afford that, but it's there are some advantages to doing just 6 rounds of chemotherapy and you're done. Okay? As opposed to being on it. But anyhow, that's not the topic really tonight. So, a little bit about this thing called ARV7. I don't know if you have heard about this. Any of you heard of ARV7? No? Okay. So this is kind of a big deal too. ARV7 is a mutated androgen receptor. Well, what's that? Well, the androgen receptor is the key receptor for prostate cancer, right? It is a little protein. It's a receptor that sits in a prostate cancer cell. Okay? There's also androgen receptors in other tissues in our body, our muscles, our bones. But definitely cancer cells have an androgen receptor. And the way that it normally works is testosterone floating around, okay, produced in the testicles or adrenal glands, bind to that receptor, attach to that receptor. that receptor complex goes to the nucleus, cells let's go, and the cell starts dividing, spreading, growing. So you need this androgen receptor for cancer to grow, okay? ARV7 is a mutated. Something happened to that receptor, and it's not a normal receptor anymore. So normally, the androgen receptor binds testosterone at a specific site, okay? And I have a picture here, all right? So here's the X chromosome, and if you don't think God plays funny tricks on us, you all know what the X chromosome is, female. And here's the androgen receptor on the female hormone, so go figure. Okay, it's not on the Y chromosome, but the Y chromosome is just a teeny little chromosome. But here's the gene, here's the complementary DNA, and here's the receptor. Basically, you don't have to, but here's the protein spread out. This is where the testosterone binds. It sits in here. And when testosterone or dihydrotestosterone sits in there, this attaches to the chromatin or of the chromosomes, and that tells the cell to start growing. Well, what happens in ARV7 is this is gone. It's not there anymore. It's lost, or they don't have this. There is no ligand binding site. So as a result, you don't need, doesn't care about any testosterone or DHT. But that receptor activates itself and stimulates the cell. Okay, so that's a bad mutation, right? That's a bad one. It doesn't matter whether you have T or DHT, it's going to activate. So these tumors tend to be resistant to our best treatments. So once your hormone therapy stops working and I say, let's get you on abiraterone, which is called Zytiga, or enzalutamide, which is Xtandi, highly effective in most men, but about 20 to 20% of men have this ARV7 tumors. It's not going to work. It's not going to work, or it's going to work minimally. Well, right now, we don't know how to measure that. Soon we will be. But the key point here is these tumors are sensitive to chemo. Doesn't bother chemo. So if we know you're ARV7 positive, and there's going to be a test out relatively soon, probably within the next 3 to 6 months, it's a blood test, that'll tell you, are you ARV7 positive or not? And if you are, hopefully you're not, but if you are, may not want to even try some of these, quote, easier medicines. You may have to go directly to chemo, but will be more effective. Okay. So the very aggressive prostate cancers, you don't want to spend too much time because they're rare, fortunately. I see one every few months, and so it's not like an everyday occurrence. And this is where, you biopsy the tumor and it shows this neuroendocrine features, which are very aggressive. Often it attacks visceral organs like the liver or lungs, and not so much the bones, which is where prostate cancer typically spreads. And the PSA may not even be very high. Just doesn't make much PSA. It's a very aggressive tumor. But if you give chemotherapy that includes platinum, carboplatin or cisplatin, it can be very effectively treated. Very effectively treated. If we know what it is, we use this chemo. Okay? And it's interesting that we are seeing perhaps more of this because we have so many better drugs now, like Zytiga, like Xtandi, like Xofigo, like Provenge, that men are living longer. Men are living longer with advanced disease. And as they're living longer and getting more of these really good treatments, at the end, some of these cancers are then becoming more aggressive. But we do have methods to treat it. Okay? So how does it fit into the sequencing? So this is a little kind of figure that shows the course of a prostate cancer over time. This is tumor burden on the y-axis. You could say PSA or scans, whatever. Over here you have local therapy. Prostatectomy. Cliff, where's Cliff? You had your prostate removed, your PSA tumor burden goes to 0, and that's where you are, thank God. Great, good for you, and I wish everybody was like that. Okay, or you have radiation, everything is gone, here you go, way out here, you're good. Fortunately, that's not true for everybody, okay? Otherwise, I wouldn't be standing here, I'd be doing something else. All right? So, yeah, it works, but in some men, here it comes, here it comes. It starts to come back, okay? Now, for a lot of men, this is called a biochemical recurrence. It's just the PSAs come back, and there's still things we can do. If you haven't had radiation, you can have radiation. But men ultimately end up needing hormonal therapy. And if at the time it goes up, we find that there are metastases when it has spread. I'm sorry, it has come back, and it's spread to some bones. They basically feel okay, but that at that point, we use hormonal therapy, we use the androgen blockade, but we are now beginning to use docetaxel way over here. That's the Taxotere chemotherapy, okay? What we expect it to do is have a significant drop in the tumor burden. The PSA often goes to 0 or undetectable in the majority of men. And I wish I could say many were cured, but most will at some point, and this can be months to years, will again begin to grow. Okay, what we're hoping by using the Taxotere early is to kill as many of those bad guys that are sitting over here so that this inevitability is going to be way out here. A lot of what we're doing is just setting back the clock, pushing it back. If we can't cure it, I wish we could, let's at least keep setting the clock back, right? It's just more time. It's more time, okay? Keep the cancer from growing and mutating and getting bad, okay? But really, once the cancer starts to grow, in spite of hormonal therapy, we have a lot of things we can do. Enzalutamide, which is Xtandi, abiraterone, which is Zytiga, RAD223, which is Zofigo, Sipuleucel T, which is Provenge, okay? But really, anywhere along the way, chemotherapy can be given. Now, particularly in symptomatic men, but even not, it can be given based on the judgment of the oncologist in a discussion with the patient, okay? So where it used to be only way out here, okay, and then it held Cabazitaxel, etc. Mitoxantrone's an old one. I don't know why that's still there. We're using it earlier, okay? And there's research now looking at drugs like Cabazitaxel, which some people think may be, in some ways, at least as good, if not a better drug, also looking at that early. So what are some of these chemotherapy myths? Chemotherapy doesn't really work. Well, there's level 1 evidence that it does improve survival. It typically drops the PSA big time and typically improves symptoms. So chemotherapy does work. Myth 2, chemotherapy should be reserved after all other treatments have failed. Well, that's not true either. Look at CHAARTED and Stampede. If we use it early, men live longer. Okay, if we know it's an IRV7 tumor, avoid ineffective treatments. Okay, and it's better tolerated when patients are healthier. Myth 3, side effects are intolerable. That's not true. There's much improvement in management of side effects. As I said, many men will say it wasn't as bad as I thought it would be. Myth 4, my urologist doesn't think it's necessary. Well, this is an interesting point, and this gets into sort of the handoff between, or I should say the association or relationship between urologist and oncologist, because both urologists and oncologists take care of men with prostate cancer, right? And it's actually one of the few fields of cancer where both modalities, both disciplines, are still pretty involved. And urologists have every right to be involved. First of all, many men with prostate cancer have urologic problems, right? You can't pee. You pee too much. Maybe you go into retention and end up in the ER. You have to have a catheter. I don't know how to handle that stuff. That's not my area. That's urologist. And you need them. Okay? Or if you need Flomax or all these different medications that they use to help your urinary symptoms. Now, not all men with prostate cancer have urinary symptoms, but quite a few do. So we do need the urologist as part of the team. Okay? Also, the urologist has probably known you for many years. Right? Probably knew you when you were a young man when maybe you had a kidney stone, right? And then something else happened, and then you had your prostate cancer, and maybe he removed your prostate, and then maybe he's known you for 15, 20 years, okay? So for the urologist to go, okay, now you have cancer, go see Dr. Shevrin. It's kind of like, So I respect that, and I try my best to maintain a relationship with them, but Sometimes urologists tend to hold on to patients, in my opinion, too long. And they may not be as up to date on the latest things with chemotherapy or when to use chemotherapy. That's not what they do. They're surgeons. They're busy surgeons, okay? And they operate, okay? And so some urologists, certainly not all, many urologists are saying, you know, you need to go see an oncologist. You need to go see Dr. Shevrin at this time, okay? Is many urologists kind of wait and wait and wait, keep giving Lupron, aren't really monitoring, and the next thing you know, the cancer's gotten pretty bad. And then they say, well, now you better go see the oncologist. So I think there needs to be some education also for some urologists to think about these issues and to think about using these drugs, you know, chemotherapy earlier, even though it may mean referring his or her, mostly his patient, to you after they've known you for many years, okay? And that's an ongoing point of education. And I think that's it. Thank you. Any questions, comments? Yes?
Why would you use chemotherapy over radiation, or you said you use it sometimes chemo and radiation? Oh, sorry.
Don't usually use chemo and radiation in prostate cancer. That we do.
Oh, okay. I was wondering why would you use chemotherapy over radiation? And I know you said sometimes you have chemotherapy with radiation, but why would you use?
Well, first of all, radiation. We'll talk about radiation. What's radiation? You know, radiation. Who here's had radiation? Okay, so radiation is used for one reason is to try to cure your prostate cancer. Right? You get 40-some treatments to your prostate in hopes it'll wipe it out, and you do that instead of surgery. That's treatment as primary therapy. Try to get rid of my cancer, okay? So we don't give chemotherapy at the same time you give radiation. We give hormone therapy. If you have a big tumor and you say it's too big for surgery, or I don't want to do surgery, okay, then we'll send you to the radiation oncologist who's going to do the radiation, and at the same time you get hormone therapy for a while because they work together, but not chemotherapy. Now, the other reason to give radiation is if there's a bone, let's say, that's really hurting. You have a tumor in a rib that hurts. You can radiate, you zap it. That's kind of like what we call spot welding. You don't need 40 treatments. You probably only need 10 or 11. And it knocks the pain out. It knocks the pain out. And more recently, we're using radiation, and I'm finding, because we have some new scans out, and that's not the topic tonight, where we find there's one lymph node that's making all the PSA, and that's the only one. It's spread to one lymph node. Well, let's go after it. And we can do a special kind of laser beam type radiation for them, okay? But we don't, now that person may be getting chemo at the time, but we don't give those together. Does that answer your question? In some other cancers, they are given together, but not in prostate.
This has to do with the clinical studies that you were talking about, and the results of the clinical studies which said that there was an average improvement of 15 months lifespan, for instance. But there's really a range, isn't there? Aren't there? Some men are much better than 15 months.
That's a median. Remember, think of a bell-shaped curve. Right, that's just a median.
So what would be like the longest that it might be effective?
Well, you know, CHAARTED started enrolling probably 8 or 9 years ago. And so we do have some men who have been followed that long, okay? It wasn't approved until just 2 years ago. But I was part of the trial, so I did have experience with it back then. I probably had a dozen or more patients on that trial. It's only approved 2 years ago, so it's too soon for most people to know, that give you an answer to that. But I've had men where they're living well beyond what I would normally expect, okay? More than that 15 months or year and a half. They're 2, 3+ years out. So it's a pretty broad bell-shaped curve. Now, on the other end of it, if the cancer is very aggressive, you know, it may come back sooner than that 15 months. But it's buying at least median half more, half less of time. So yeah, there are those who can get quite a bit more.
And another good point to that is it gives more time for newer drugs and new treatments to come
It's
out.
always good to be alive, right? As we know, the more you're around, the more stuff comes out, and that's the key. Keep me around. You never know. You see, you read the paper, there's a lot of stuff out there, so yeah, that's definitely important.
You were referring to some very large amounts of money to get
Given
these
to me?
drugs from wherever you get the money. If you don't have the money and you cannot afford the drugs,
Oh, the drug, okay, yeah.
the chemotherapy,
No, not the chemotherapy. Chemotherapy is cheap. I'm talking about those new hormone pills.
okay,
Chemo's cheap.
okay,
Chemo's intravenous. Medicare pays for that. Every penny.
okay,
No copay for chemo.
okay,
Big copay for pills. Right? Medicare Part B pays for injections. And up until George Bush did Part D, it didn't pay for pills. You know that.
right,
Part D comes along, at least you get some help, but you got the damn donut hole
yeah,
that you have to get through. And then you have to pay 5% the rest of the year. Well, that's fine if it's a $50 pill, but if it's $10,000,
At that point, are you referred to your friendly undertaker?
okay.
That was my question.
Oh, I see. Well, all right. Look, you do what you got to do. And it's true that this is a challenge for all of us. We call it financial toxicity. And that's what it is. It's too expensive. And we're looking at our politicians to try to do something about this. And so far they haven't. The pharmaceutical companies still, make a lot of money. On the other hand, pharmaceuticals have provided us with these amazing drugs, right? They're innovative. They're innovative. I mean, these drugs that are used all over the world, are amazing. They've changed my practice. So I have to give them some credit for that. And they do have to pay for their R&D. Now, you can argue all night whether they're making more than they should or less than they should, or whether it's subsidized, because we pay more than, let's say, Germany or France. Why? Because they have socialized medicine. And so they have a whole different way of paying for it. But that gets into a whole other thing. But chemo is inexpensive. That's one advantage of it. You don't have any copay getting an injection.
One second, please. I'll bring the mic to you. Here you go. 1 second, please.
Wait a minute.
Is Provenge still being used?
Yeah, it's being used. Yeah, it's not really a topic of tonight because it's chemo, but Provenge is immune therapy. I don't think it's being used quite as much, but yeah, it's still being used. It's an immune therapy. It's a little hard to know if it's working or not because there's no way to really tell. PSA usually doesn't drop. It's a way to enhance your immune system, and hopefully that will help. But yeah, we still use it.
Dr. Shevrin, who has the responsibility of finding clinical trials? The oncologist, urologist, or the patient?
All the above.
Okay.
Yeah, all the above. I mean, I think for patients it can be challenging. There are websites, but and actually, Chuck may want to talk to that because UsTOO is really making a big effort to have information on their website to allow men to find clinical trials more easily, because the clintrial.gov website is huge. I mean, you have to kind of know how to use it. Say, how many trials are there for prostate cancer? Well, there's like 10,000. Well, that doesn't help you. Well, I want to see it for bone mets. Well, there's 2,000. I mean, so you have to really, focus your search, and it can be tricky. But, I don't know if
Yeah, that's a good point, because we do have a new service called the Clinical Trial Finder on the UsTOO website, and it's populated with all of the clinical trials that you'll find on clinicaltrials.gov, but it's very, very user-friendly. It just based on the patient's responses to a few questions that gauge the health of the patient specific to prostate cancer, along with even preferences in terms of where you might want to conduct your clinical trials. It will produce a short list that is specific to your criteria. And the other great thing about it is if there's someone that doesn't want to go online and use the clinical trial that we have on the website, there's a toll-free number you can call, and a navigator will walk you through the whole thing, and they speak both English and Spanish. So it's a great resource, and we encourage everyone to take advantage of that.
I've got one other quick question. I've got a friend right now that's going through lung cancer, and he's getting 3 shots 3 weeks apart. Now, I got a neighbor that went through it at the University of Chicago. 6 weeks of daily. Have they changed the format, do you think, of daily chemo?
For lung cancer?
Right.
Daily? I'm not aware of any.
6 weeks ago, yeah.
Every day?
This has been 2010, I think he had it done. And he's fine now.
Oh,
my
good.
neighbor.
It worked.
My friend, I don't know yet.
Yeah. Most chemotherapy is given every 2 to 3 weeks, typically. I don't know what a daily one, unless it's a pill. There are a few chemo pills out, and you take those every day.
But he went down to the University of Chicago.
Yeah, well, I know what's going on down there. I mean, that's where my academic appointment is. So I'm not aware that they have chemo every day. May have been radiation every day plus something. That may have been what it was. Okay. Yeah, don't know about that. Yeah.
My question is regarding your 6 rounds of chemotherapy. What does that consist of? How does that work?
So you come to the clinic like Kellogg. Okay, you see me. How you doing? Get your blood drawn. Okay, let's say it's your 3rd round. Okay. We make sure your blood count's okay, that you're feeling okay. Hopefully your PSA is dropping and feeling good about that. We escort you by our treatment nurse to one of our treatment rooms where we usually have a little portacath, or sometimes it's in the vein. You access this with a special needle, sitting in a chair or in a bed, IV pole, there's a bag, it drips in over 1 hour. You sit there, watch TV, read a book, talk to your wife. 1 hour, turn it off, you leave. See you in 3 weeks. It's every 3 weeks. Okay, so it's actually not very time consuming. Men on chemotherapy travel, work, go to movies, go out, live a life. They really do. They don't go home and throw up and go to bed.
So when you say 6 rounds, you're doing that only 6 times? Is that what you're saying?
6 times 3 is 18 weeks.
18 weeks.
4.5 months.
Okay, that's
And
what
you're
I wanted
done.
to know.
That's if you do 6. Yeah, you're done at 4.5 months.
Okay, great.
We do have a couple of questions that came through online. Please comment on low dosage chemotherapy done more frequently, for example, weekly. I think that you somewhat covered that, but if you could please address that question specifically.
Okay, so chemotherapy, and I think this was under the slide where I said you can adjust the schedule. Taxotere chemotherapy and Jeutana chemotherapy are currently recommended every 3 weeks, but other regimens with those drugs have also been utilized. So in men who are a little more frail, where I don't want to give them a big hit of it every 3 weeks, I'll divide it up and give smaller doses once a week for 3 weeks in a row. It's kind of like little left jabs instead of a big right. And that can be a little better tolerated, not quite as much. We think it's probably almost as good, maybe not quite, but it may be enough just to keep the cancer at bay and not as toxic. So yes, if a man can't do the every 3 week, we can adjust the schedule and give smaller doses more frequently.
Okay, we have another question from the webcast audience. When do you start chemo with CRPC?
Well, that's a little bit like what I showed here in that one slide, that CRPC, currently the recommendation by NCCN is that it started for symptomatic, okay? So we usually don't offer chemotherapy if a man feels absolutely fine, okay? No symptoms at all, feels great. The only time I might do that is if I realize that the treatments that he's getting aren't working. You know, whether it's Xtandi or Zytiga are not working. The PSA is continuing to rise, especially if the PSA is rising rapidly. Okay, it's one thing for the PSA to double in 6 months, 3 months. But if you see that PSA doubling every 1 to 2 months, do the math. Let's say it's 50. Come in a month later, it's 90. Like, wow. You come in another month and it's 150. I know what's going on here. You may not be symptomatic that minute, but probably within the next month or two you will be. So at that point I will probably be talking about chemotherapy. Or if a man is having even mild symptoms, but it's frequently we will use some of those other hormone therapies first, like Xtandi and Zytiga. You've heard of those drugs, right? These are the new pills that are used in those circumstances. But I tend to be ready to use it a little bit earlier, okay, when I see the cancer is beginning to show signs of aggressiveness.
Okay, another question that came through online. Is chemotherapy possible for individuals with early stages of prostate cancer?
You mean like when they're first diagnosed? There are several clinical trials, you're speaking of one in particular that's been going on for a while, that men who have very high-grade cancers, 9s and 10s, you all know what I mean by high grade, right? The Gleason is 4+5, 5+4, 5+5. Okay, there's been a adjustment of that grading, by the way. It used to be that high grade was 8, 9s, and 10s. Now we're looking at dividing 8s out as not as bad. So 4+4 is not as bad. Shouldn't be grouped with 9s and 10s. So we're talking about 9s and 10s. These are bad, aggressive tumors. Okay, so men who are going to have surgery, to have a prostatectomy, we are concerned that that's probably not going to do the job. And so there's one big clinical trial where half the men, prior to going on getting their prostatectomy, get some chemo up front and see if that does anything. So that's the one example of trying it early. But for the most part, we don't use chemotherapy for early, just like when it's first diagnosed and localized. If it is spread somewhere, that's a different story.
Okay, another question through the online audience. Is ARV7 more common in men with high Gleason scores? I am 4+5.
That's a good question. And I'm not sure I can actually say for certain that it is. Somewhere in the recess of my mind, reading through the articles that have been published by the group at Hopkins with ARV7 say that they do tend to be a higher grade, but I don't think that's across the board. So I think you can see men who have ARV7 who have just 7s, not necessarily the 9s and 10s. That's a good question.
Why is it that men must endure palliative hormone therapy prior to being offered potentially curative chemotherapy?
Well, let's be clear on this. Chemotherapy is not necessarily curative. We're not talking curative. We're setting the clock back. We're killing bad cells to allow the disease to be pushed back, okay? That's what we're doing. Chemotherapy is not curative. The only cancer, there's only a few cancers once they've spread that are cured by chemotherapy. Who knows what those are? What's one cancer that young men get?
Testicular?
Exactly. Lance Armstrong.
Good guess.
Good guess. Lance Armstrong had cancer head to toe. Head to toe. Now, you can say Lance Armstrong is now not in such great shape, because of all the stuff he's done, but he's cured. He is cured. I can cure men with testicular cancer even though it has spread to their lungs and everywhere else. Certain lymphomas, that have spread to lymph nodes can be cured with chemotherapy. Okay? But once, let's say, lung cancer is spread, colon cancer is spread, breast cancer is spread, chemo can prolong survival significantly. You can live with the disease. The point of prostate cancer, like many cancers, especially prostate cancer, because it often is a more slow-growing disease, is you're going to live with it. It's a chronic illness. Do you cure diabetes? Do you cure rheumatoid arthritis? Do you cure COPD? No. You'll die of it someday, right? You're going to die of diabetes or COPD, probably, if you have it bad enough. So you're going to live with it for years. Okay, so I hope I didn't say that. So yes, chemotherapy has a role to play, but it's not instead of hormone therapy. Hormone therapy really remains the foundation of treatment for advanced prostate cancer.
So that was the last question that I had from our online audience. Are there additional questions from the in-person audience?
Yeah, I had one question. I was wondering, I think I know the answer, but I'm not sure, do you find the more advanced cancers where you might be more apt to use chemo in older men, or is it across the board? Can younger men get the same thing, and does that happen?
One
often?
myth is that older men's prostate cancer is always indolent and slow. Not true. I can tell you, my clinic today, number of men in their 80s, very aggressive cancers, high grade. A lot of young men, slow growing. Now, the thought is that in general, younger men have more aggressive than older men. And I would say that, I can't say never occurs, but I've not relied on that at all, okay? It's kind of an equal opportunity disease, unfortunately, okay? So it's true that some older men do have more slow-growing tumors, but I think what we've learned about that is if you're 80 and you have a 3+3 slow-growing tumor, then it may not be a bad idea to do nothing. Because if it takes 20 years for that cancer to kill you or to get bad, well, maybe you're going to live to 110, maybe, I don't know, but probably not. Now, if you're 60, well, you have to think twice about it, okay? On the other hand, so that's why we have not been screening older men as much, okay? But there's been some debate about that because just because a man is older doesn't mean that, the cancers that we find are always slow growing. They can be fast growing as well. Yeah.
We have another question that came in online. I have had 10 rounds of Taxotere, 1 each 3 weeks, with a total decrease in PSA of 71% from almost 16 to a little over 4. Original diagnosis in 2004. Xtandi with success for 2 years, and Zytiga with no positive response preceded chemo with Taxotere. How long does Taxotere continue?
We usually don't extend it beyond 10 cycles, so his oncologist probably stopped at 10. Okay, that would be considered a treatment round. We say, let's stop. You've got your 70% drop in your PSA, which is awesome. Okay, by that point, there's no evidence that going beyond 10. Occasionally, we'll do it a little bit more if the PSA is still dropping and the patient says, I'm feeling great, I feel fine. But usually by 10 cycles, the side effects have built up. So at 10 cycles, usually where we stop. And that's a great response, 70%.
I'll bring the mic to you 1 second, please.
There's been a big controversy about screening men. You touched on it a minute ago.
I shouldn't have brought up screening. I should have brought that. This is about chemo. No.
I know, but
but
okay.
You're going to
Your
ask it
opinion
anyhow.
on screening. In other words, I always thought that especially if you have cancer and if you got prostate cancer, I'm on my son to get screening, and I'm under the opinion that over 50 you're supposed to start screening, and especially if your father has had prostate cancer.
That's correct.
But then you read these articles, they say, oh no, screening, you're going to die. It's such a slow-growing thing,
That's
you're
not
going to
happening
die
anymore.
anyway.
That's done. No one's saying that anymore.
Oh, okay.
No one's saying that anymore. That was the task force, and that was reversed.
Good.
That was reversed. And no one's going to say your son shouldn't be screened. All of them will say he should be screened if there's a family history.
What about people that don't have a history of prostate cancer?
That's different. The current recommendation is a discussion with your doctor, like your internist. It's not an automatic, like a pap smear for women. That's an automatic. You got to get one, right? Mammogram. This is a discussion, pros and cons, starting at age 55. 55 to 75. Okay, or younger if you're African American, because they get it a lot, or a family history.
Okay, thank you.
My question is about Gleason scores. You mentioned they were kind of bumping out to Gleason 8s. But it seems to me like if you have a 5+5 or a 4+5, a 3+5, as long as there's a 5 in the equation, seems to me like it's still aggressive
That
cancer.
could be, yeah. 3+5s are very, very rare. Do you have a 3+5? Oh, okay. Yeah, that's unusual. Usually you don't have 3 and those are the only two scores, 3s and 5s, or is it 3+4 with 5? I don't know.
It was 3+4 and a tertiary 3+5.
Okay, that's a little different. So you have 3 scores. Yeah, okay, but you're a 3+4 with tertiary 5. We would put you in a little worse category than a usual 3+4, which is actually pretty good because you have a little bit of 5. It wouldn't push you to the highest score, but you'd be somewhere, in the middle.
On the good side.
Yeah. Think about right. All right.
Okay, well, thank you very much, Dr. Shevrin.
Okay.
It's a great talk. Appreciate it. I know I learned a lot, and I think everybody out there in webinar land has probably learned a lot too. And we're glad you could all participate. And remember, this will be up on the UsTOO website at some point in the not too distant future if you'd like to look at it again, especially those graphs. I really like those. So if there are no further questions for Dr. Shevrin, I think we'll call it a night. See you again next month. Not the webinar people, my people.